All right, we're going to pivot now, and we are going to now have an opportunity to talk about some of the data for HIV prevention with long-acting agents. And I just want to parenthetically say that to people who had questions about treatment that we didn't get to, we apologize. We'll try and get you answers as much as we can before the end of the webinar to your questions, but apologies if we didn't get to yours. We're really delighted now to have Dr. Colleen Kelley, who is from the Emory University Division of Infectious Disease. She is a multifaceted and multi-talented clinician investigator at Emory, where she works as an outpatient clinician in the Grady Infectious Disease Program, and sees inpatients on the infectious disease consult service there, as well as in the special immunology service at Grady at Emory. Her research focus is on biomedical HIV prevention, interventions, including pre- and post-exposure prophylaxis, as well as vaccinology. She also conducts translational immunology studies on HIV susceptibility in men who have sex with men to better understand rectal transmission biology. She works closely with the HIV Prevention Trials Network and the HIV Vaccine Trials Network at the Hope Clinic in Atlanta. And she also has close collaborations in the School of Public Health on several HIV prevention studies, including PrEP implementation in the Atlanta area. We're really delighted to have Dr. Kelley here. And Colleen, the floor is yours. Thanks for joining us.
Thank you, Dr. Landowitz. It's really glad to be here, and I'm glad to have the world expert in long-acting prevention to lean on if there's any questions. So I will go ahead and get started. These are my disclosures here. So the learning objectives today is we're going to examine very closely efficacy and updated efficacy of long-acting cabotegravir for HIV prevention. We're going to look at HIV acquisitions and diagnostic delays that have occurred in CAB-LA users. And finally, going to review the updated clinical practice guidelines for PrEP as they've changed with the introduction of long-acting cabotegravir. So first, to get started with the first audience response question, number 1, use of CAB-LA for prevention has been shown to be superior to oral TDF-FTC in all populations at risk of HIV. So go ahead and put your answers in. And whenever we're ready to share the results, go ahead. Okay, so about 50-50, true or false. And so on the next slide, I will give you the answer. That answer is actually false. So in the HIV prevention landscape, we are on the precipice of having so many options for people who can pick and choose what's going to work best for their individual sex lives, for their individual behaviors, for their individual schedules. And this is really exciting. In 2005, we first got post-exposure prophylaxis, and that was all we really had from a biomedical perspective. And then oral TDF-FTC came on a daily basis in 2012. In 2019, we got on-demand 211 PrEP, as well as FTAF, tenofovir alafenamide, for people with kidney disease. We also, for cis women, are awaiting implementation of the dapivirine ring. And then 2021 brought us injectable CAB-LA, which we're going to go over in greater detail today. The thing to note is that with choice becomes complications, right? Each of these interventions have been studied in certain populations, and not all of them are appropriate for all people. So to answer the audience response question on the last slide, injectable cabotegravir is only appropriate for people at sexual risk because it's not yet been studied in people who inject drugs. Theoretically and hypothetically, it should work in people who inject drugs, but we just don't have any data as of yet, and so it's not yet been recommended. And just to remind everyone, this is what the prevention pipeline looks like. It is a really exciting time to be working in HIV prevention because there are so many options that are coming to our patients, which is really going to help expand possibilities for everyone. And so if we look closely, there's diaphragms, enemas, more injections, more long-acting injections, implants, patches, pills, vaginal films and gels, etc. And so we are looking at a future of many options for people, many choices for people to be able to select the product that works the best for them. And that is really exciting when we think about reducing new infections. So just to review in detail, the clinical trials that brought us long-acting cabotegravir for PrEP, these were done by the HIV Prevention Trials Network, 083 and 084. And so I'm going to go over these very briefly because I think a lot of people are probably familiar with the overarching results. So just to remind everyone, the design of HPTN 083, which was men who have sex with men and transgender women, people were randomized to receive either injectable cabotegravir every 2 months or oral TDF-FTC after an oral lead-in period. That was continued until the DSMB stopped the study early, and we'll go over those results in just a second. At which point in time, everyone, to cover people who had injectable cabotegravir, it was recommended that they receive oral TDF-FTC for up to a year after their last injection. Once the DSMB results were released, however, the study rolled over into an open label extension where for about a year, people could choose whether they wanted to remain on injectable cabotegravir or switch back to oral TDF-FTC. And then finally, we are now currently in the study in open label extension with cabotegravir injections only that are being delivered through the study. So from the seminal results in New England Journal of Medicine, this was the initial efficacy results from when the DSMB first stopped the study. And what we saw was superiority of cabotegravir versus oral TDF-FTC on a daily basis. And that was really related to lower adherence to oral TDF-FTC than to injectable cabotegravir, which is really, really important. The hazard ratio showed a 66% reduction in HIV incidence in the cabotegravir arm, which was just incredible. 84% of people have injection site reactions in the clinical trials cabotegravir, and that's for MSM and transgender women. I'm going to show you slightly different results for the trials in cis women. There were some small differences in weight gain to be noted, but nothing significant in lipids. And we're going to talk a lot today about integrase resistance. And I'll touch on it briefly in this talk, but Dr. Aaron, who follows me, will talk more extensively about integrase resistance. And that was seen in breakthrough infections or people who acquired HIV while getting cabotegravir. There was also breakthrough or people who that acquired HIV with oral TDF-FTC, and that happened twice in that arm. And that's also something that's important to note. So just last week in Lancet ID, the 1-year unblinded analysis follow-up was just published by Dr. Landevis and colleagues. And so this was the period where people could choose, it was open label, people could choose to remain on injectable cabotegravir or stay on oral TDF-FTC while they were waiting open label extension for everyone to be able to get injections. And that confirmed the hazard ratio of a 66% reduction in injectable cabotegravir. So after the unblinded phase, still with a 66% reduction in incidence of CAB compared to oral TDF-FTC, which is really just incredible to think about. Oral TDF-FTC, such a highly effective and amazing intervention, and cabotegravir even improves upon that. Just to review very briefly those differences in weight change, as well as some differences in bone mineral density. So you'll see here on the left, the panel that shows the overall difference in weight change in the cabotegravir versus TDF-FTC arm. And you'll see that the weight differences actually occurred very early in the study, before week 40. And that was attributable to a slight decline in weight in the TDF-FTC group. So as we're learning more about tenofovir disoproxil fumarate and its associations with weight loss, rather than cabotegravir actually being causing weight gain, is the current hypothesis around that. So very, very small differences seen very early. Also, as you might expect, there were some declines in bone mineral density seen in the tenofovir emtricitabine arm, while there were no declines seen in the cabotegravir arm. So now let's review HPTN 084, which looked at in same study design, and this occurred in cis women, majority in sub-Saharan Africa. And this is important because it gives us additional data on efficacy of cabotegravir, but also as well as adverse events. And so what was really incredible for cisgender women who historically in HIV prevention trials do not always show efficacy in those clinical trials due primarily to adherence. This really was an astounding result, an 88% reduction in HIV incidence in the cabotegravir arm compared to the oral TDF-FTC arm. Again, daily TDF-FTC has been problematic for cisgender women in sub-Saharan Africa. Daily adherence has just been challenging. And again, 42% with detectable drug levels showed that, again, it was challenging in this clinical trial setting. But adherence to injectable cabotegravir was much better. You'll see that there were lower injection site reactions in this study compared to HPTN 083, and that's something of interest to compare. Again, there were small differences in weight gain seen in this study, similar to HPTN 083. And really the most important data aside from efficacy that we'll get from HPTN 084 is safety and pregnancy. So in the initial results, the top line results that were reported, there had been 49 confirmed pregnancy and no anomalies, no congenital anomalies had yet been reported. Since that time, of course, the study has been following incident pregnancies in order to report those outcomes. And two updates just to show you on the left, one reported at R4P, and then another that is a follow-up from the HPTN show that many more pregnancies have occurred. And to date in the open label extension, up to 268 pregnancies, and likely more by now, I'm sure, are being followed for outcomes. And so far, there is no signal of congenital abnormalities, which is really important as we think about expanding this important prevention intervention for cisgender women. So let's shift gears just a little bit and talk about the people that are very rarely acquiring HIV on injectable cabotegravir. This is such an important intervention. It is really highly effective, even more so than the highly effective oral TDF-FTC. But occasionally HIV infections or acquisitions are occurring. And so when are these acquisitions occurring? And this is important when we think about the pretest question that you all answered around this. It's important to understand that so we can be mindful of this and we can watch out for it in our clinics. So some people in the studies acquire HIV at baseline, meaning they were HIV positive at the time the injectable cabotegravir was started. Others, and this is the majority of cases, actually acquire HIV long after they've received their last cabotegravir injection. For more than 6 months after the last cabotegravir injection is when the majority of cases are actually occurring. A small number of cases have occurred in oral phase lead-ins, as well as a very small number that have occurred with on-time injections. So people that are getting those 2 monthly injections as scheduled, a small number of infections have occurred. Delayed infections have also been a very small number of HIV acquisitions. You can see those are delayed, but less than 6 months, which is the top category of HIV acquisitions that occur. And then finally, also remembering when restarting PrEP, and this is true for oral or injectable, we need to be sure the HIV acquisition hasn't occurred in the timing of lapse from PrEP. And there have been a couple of cases when cabotegravir was restarted more than 6 months after the last injection, where HIV was already present and cabotegravir was restarted. So really important to note that if we include those last two there on the bottom, where cabotegravir was restarted more than 6 months after the last injection, plus the category B, where HIV acquisition occurred more than 6 months after the last injection, that's really where we're seeing the majority of cabotegravir seroconversions. So really just to hammer home, people getting on-time injections or even people getting delayed injections, HIV seroconversion is extremely rare. We're seeing most of the HIV seroconversions long after the last cabotegravir injection was given, so more than 6 months. And why is this important? And I think we all have probably heard and maybe have even seen in some instances, pre-exposure prophylaxis will sometimes delay HIV diagnostic seroconversion with standard tests. And this was really highlighted nicely in this JID paper from 2021. And I remember when I first read this paper, it was really just mind-blowing because I love HIV diagnostics. And when I saw this test variability in test results that was occurring over very small periods of time in people who are on injectable cabotegravir, it's really just fascinating and very confusing and very hard to dissect. And so I recommend people, if they haven't spent much time with these graphs, really looking at what was happening with viral load, with antigen antibody positivity, as well as confirmatory testing over time in people who acquired HIV while using long-acting cabotegravir for prevention. So in the trial, in this initial paper from 2021, and we have more data since then, there was evidence of delayed detection that occurred in all 4 of the baseline HIV positive cases, as well as 7 of 12 incident cases. There was also delayed detection that occurred in the oral TDF FTC arm in about 7 of 39 incidence cases. In almost all cases, if you included viral load testing in your HIV diagnostic algorithm, it would have captured those cases and not delayed the recognition, the clinical recognition of HIV infection. It is really important to note, though, that the delayed detection of HIV in people with CAB-LA is much longer than that in people who use oral TDF FTC, on a median of about 3 months before the HIV diagnosis is actually detected. Whereas TDF FTC is much shorter and really begs the question that we'll talk about a little bit more about viral load monitoring. The thing that I just find so fascinating is this assay reversion. So you'll see people that have a positive antigen antibody, then negative, same thing with viral load, positive to negative, then positive, positive to negative. This is really just fascinating as we think about what's happening between the virus and the host and the drug in people who are acquiring HIV, but it does make it difficult clinically to confirm the diagnosis. So when this was realized, the HBTN OA3 study changed its follow-up testing algorithm. So in the initial unblinded period, we were using FDA rapid tests as well as antigen antibody tests, something similar to a 4th generation in almost all cases. But once it was recognized that these diagnostic delays were occurring, an HIV viral load was incorporated into all follow-up visits. And so ongoing studies are occurring to understand whether this HIV viral load will assist us in diagnosing HIV in people who are seroconverting on cabotegravir, and should it be implemented on a wide basis. But the CDC kind of beat the study to the punch and incorporated this into their clinical practice guidelines. So in 2021, we got an update to the CDC clinical practice guidelines. And just to mention, one of the most important things I take home from these guidelines is in who should get PrEP. And the CDC shifted gears a little bit and said that all people who desire PrEP should be offered PrEP. So this is really, really important. We no longer need to assess someone's risk and determine whether someone is high risk or not. We should certainly talk to people about their behaviors and counsel them on their behaviors. But if someone wants PrEP, we should be offering PrEP. And this is really, really important. The other change to these practice guidelines was an HIV RNA assay was incorporated into routine oral and injectable PrEP follow-up visits. I think some of us were a little bit surprised at the incorporation into the oral follow-up. And I should note that the IAS-USA guidelines, the sponsor of this talk today, do not recommend viral load monitoring for oral PrEP. And the WHO also states that viral load monitoring is optional. But what this has created is a little bit of complexities when we think about follow-up in implementing PrEP in our clinics. So I think everyone was very used to the 3-monthly follow-up that we had for oral TDF FTC. Our clinic protocols were in place, and people were routinely coming in every 3 months. And so when we add injectable cabotegravir to the mix, we see that things get a lot more complicated. We're now seeing people every 2 months after a 1-monthly injection for their loading dose, every 2 months for those injections, as well as antigen antibody testing and HIV RNA testing. And then, of course, we need to keep up with STI screening, hopefully at least on a quarterly basis. And so things, as I said, are getting just a bit more complicated as we think about implementing additional choice into our prevention options. And I look forward to the day when things get even more complicated, but we need to at least be mindful of this and think about very carefully about how we can implement in our clinics. So I just wanted to briefly review that viral load monitoring. So now recommended by CDC and for oral and injectable, although not by IAS-USA. And I think it's really important to think about the pros and the cons of this monitoring. And I would include both injectable and oral PrEP as we think about these. Obviously, if we implement viral load monitoring, it allows us to make the earliest possible HIV diagnosis. It allows us to initiate ART really early, which is helpful, we think, for long-term inflammation and size of the reservoir. And it may actually prevent drug resistance and preserve that integrase inhibitor class for people on CAB-LA. And we do have some data to support that we'll talk about a little bit later. But I also think a lot about the cons. I think there's a lot of takeaways that we should be worrying about. NAT testing is high cost and not always available, especially in community-based settings. Some are not approved for diagnostics, although those options are increasing as well. We have very limited point of care options, and especially point of care tests cannot get down to those very, very low sensitivity that we're going to need for people on CAB-LA. I worry a lot about over-medicalization of important public health interventions as well as inequities. If we make things too restricted for people, we are going to worsen inequities in PrEP access. And we know that that is a big driver of the current state of the epidemic is inequities of access to interventions. But that's not to say that diagnosis of HIV in the setting of PrEP, and I think less so in the setting of oral PrEP and more so in long-acting PrEP, often requires expert consultation. These cases can be very, very confusing to work out, and they're certainly not cleared at the outset what the answers are. So when a few years ago, CDC gave us a few options when we have ambiguous HIV test results in the setting of PrEP, what we might do. We might continue the PrEP and repeat our HIV diagnostics. And of course, the con or the downside of this is that we might be brewing HIV drug resistance. We could discontinue the PrEP and repeat our diagnostics, but that leaves someone who might be HIV negative at risk of ongoing HIV exposure without their prevention intervention in place. Or finally, we could initiate fully suppressive ART for HIV treatment, and this may not be necessary. The takeaway from that is it may not be necessary, and you may not know when you can stop it in the future to actually figure out whether the person needs fully suppressive ART. I'll say that when you add long-acting PrEP to the mix, you're essentially removing option 2 because there's no way to take away the PrEP. It's still there. The long-acting injectable stays around for such a long time. So you're really in this 1 versus 3 category. Are you going to just keep repeating diagnostics until you can figure this out? Or are you going to initiate ART, suppressive ART? With generally 3 drugs for full HIV treatment. I will say in my experience, I usually recommend this based on whether I have an increasing suspicion of true HIV infection, based on all of the testing results to date, based on the patient history, and based on any other clinical things that are going on with the patient to determine which of these to do. So what else have we learned from the data so far? What else has the HPTN 083 study learned? And we're going to talk a little bit about the Levi syndrome, the PK tail, which I think everyone in the world talked about and still talks about with long-acting injectables is, oh my goodness, the PK tail, what is that going to do to us? Also about PrEP in the real world and CAB-LA in the real world. And I really want to end by thinking a little bit about equity. And we'll talk about that a little bit more. So first, the Levi syndrome. This was presented by Sue Eshelman at CROI earlier this year. Levi syndrome stands for long-acting early viral inhibition. And really what this is in contrast to people who acquire HIV without antiretrovirals on board, so without long-acting CAB on board, it really contrasts to the clinical syndrome that we see that we know as acute HIV infection. And so what we get is infection during PrEP and basically smoldering viral load, very low symptoms, and then really difficulties in our standard assays detecting HIV, such that a sensitive RNA assay is often necessary to detect the virus. It can take months, as I said, a median of 3 months until the HIV diagnosis can be confirmed. And so this is kind of a long-term smoldering type condition. Transmission during this period is extremely unlikely. We learned also from the summer that people with a viral load less than 1,000 tend not to transmit HIV. And so in general, the Levi syndrome occurs at viral loads much lower than that. And so we don't worry too much about transmission in this setting. But drug resistance, certainly that's something that we are concerned a lot about. And we'll hear talk, as I said, from Dr. Aaron next. So here is my next audience response question. Based on the current understanding, people in the CAB-LA PK tail are at highest risk of HIV drug resistance when acquisition occurs. Please select true or false. It's people in the PK tail that are at highest risk of HIV drug resistance. Okay, we can show the results when we have it. All right, true. The audience thinks 75% of the time it's people in the PK tail that are highest risk of HIV drug resistance. So I think that that is exactly what we were all very concerned about, was this PK tail. And what I can tell you is that that is where, in general, when we think about HIV and we think about HIV replication in our treatment paradigm, that is where we worry about this zone of resistance. So the last dose, drug levels decline until they decline to such a point where it does not inhibit full viral replication. And it's that period of time where oral PrEP coverage is recommended for at least a year with ongoing testing. However, what I can tell you is the HPTN-083 data have been very reassuring about that PK tail. I'm not going to go into great detail about these resistance mutations. I'll leave that to Dr. Aaron. But what I want you to concentrate on is what's in this red box down here. These are HIV infections that occurred with either 10-week delays or more than 6 months of HIV, of 6 months since the last injection. And what you can see in these almost 20 infections is that is not where the resistance is occurring. Really, the HIV resistance is occurring either when the drug is initiated with unrecognized HIV infection, or the open label extension, or someone who has a true breakthrough infection with on-time injections. So the PK tail to date is looking very reassuring from a drug resistance standpoint. So that the answer to that question is actually false. So again, viral load monitoring, we learned more data from the HPTN-083 study that looked retrospectively at those HIV acquisitions and looked at if the viral load had been tested and it was shown to be positive at the time of HIV acquisition, would that have detected the resistance, or would that have prevented the resistance mutation from being acquired? Essentially, when did the resistance mutation occur? Did it occur at the time of acquisition, or did it occur later on? And in this case, the integrase inhibitor resistance mutations in this very small number of cases, actually 7 total, showed that the integrase mutations came later, such that if the viral load test was used at the time of acquisition, it may have prevented the subsequent and suppressive ART was started. It could have potentially prevented future resistance from acquiring. So real world experience, we don't have much yet. And so this is from CROI this year. This is the most up-to-date data that I've seen so far. We have nearly 400,000 people that are utilizing oral PrEP in the United States, but less than 3,000 on injectable cabotegravir. So I would have liked to tell you that there's a lot more experience with CAB-LA for PrEP, but we're just not there yet. It is really in its infancy in the US. And so we are waiting very anxiously to see more data on the rollout of injectable cabotegravir for PrEP. We have seen one acquisition, and I think Dr. Hasra will be presenting later this afternoon and likely be discussing this infection. This was one of those breakthrough infections that occurred in someone who was receiving on-time injections and did acquire HIV despite those on-time injections. Also, similar to the clinical trial, experienced the assay reversion, where positive then negative either antigen antibody or viral load tests were seen. Because the clinicians were using viral load monitoring, they did detect it as early as possible at the time of the second injectable cabotegravir injection. So last, I just want to close when we think a little bit about equity. We know that some populations are not the greatest daily oral TDF FTC candidates because of less adherence or troubles with adherence. And we've seen this, and I've already told you about cis women, but we've also seen this for Black men who have sex with men, transgender populations. And also, when we think about equity, it's also important to think about global access. These expensive medications need to be available to all those who need them. So CAB-LA efficacy among Black MSM was presented by Hyman Scott at Croy this year. And I was really just astounded to see these results that in the US, and this was a pre-specified analysis, the reduction in HIV incidence was 72% among Black MSM and transgender women as compared to non-Black MSM and transgender women, or the reduction in HIV incidence, while certainly there, did not reach statistical significance. So all of the statistical significance in the US population was driven by US Black MSM and transgender women. And this was related to ease of adherence. So adhering to oral TDF FTC was more challenging in Black MSM and transgender women. And while adherence to cabotegravir was less than non-Black populations, as you can see on this slide, it was sufficient to still prevent HIV and still show that incredible efficacy result. Finally, what we know so far about transgender women, and this is also a sub-study from HB10 083, we saw that in trans women who were taking gender-affirming hormone therapy, there was no difference in cabotegravir concentrations over time. We have not yet seen the reverse in looking at hormone concentrations over time with injectable cabotegravir, but we really have no reason to expect those results. And then finally, global access. When we think about getting the drug to who needs it, we really need to think about making it available across the world. And so injectable cabotegravir was approved by the US in 2021, but you can see here that large parts of the globe, it has not even been submitted for approval as of yet. It's getting there. Most of Europe, some important countries in South America, as well as Sub-Saharan Africa and Australia have it now approved, but many, many places still do not have access to injectable cabotegravir. And so briefly, just some other clinical pearls, and I'm going to go really fast for the sake of time. So similar to when we think about treatment, we also need to think about site of injection for prevention. So ventrogluteal is preferred, dorsal gluteal is allowed, but no other anatomical site is appropriate for injectable cabotegravir. For people with higher BMI, which we certainly see quite a bit, please use longer needles. You need to get that drug intramuscularly. There are some drug interactions to be aware of, although these are fairly unusual medications to be co-administered in our PrEP clinics. But as always, the rifamycins and some of the anti-seizure medicines are important to watch out for. We do not see any interactions with hormonal contraceptions, and none are anticipated with gender-affirming hormones, although we need to get those data out. Finally, missed injections, and I'm not going to spend a lot of time here, but we really need to think about people who miss that 2-monthly injection. The package insert tells us that if 1 month, less than a month has elapsed, you can continue on with your regular dosing schedule. It recommends if more than a month has elapsed that you need to reload the patient with that 4-weekly injection. This is a little bit in contrast to what we did in the clinical trial, but it is what the package insert says. Finally, I think planning for those unplanned missed injections is probably more important. What are we going to do for those people that we lose for a month or 2 or even longer? How are we going to ensure that they're protected from HIV acquisition? And I think this is an outstanding and very challenging question to answer. So there's a lot we still don't know. We still don't know about people who inject drugs. I don't think anyone doubts that this wouldn't be a useful intervention in that population, but we still don't have the data. We need to learn more about time to prevention efficacy. We do have some non-human primate and PK data that suggests it's fairly quick with injections within a couple of days, but we need to know more about that. Managing seroconversions, and I think Dr. Aram will touch on this a little bit later, that is such an important thing to understand better. The PK tail so far looks reassuring, but it still certainly is a risk for INSTI resistance. And so we need to see on broad scale rollout what happens. Metabolic outcomes, and then feasibility of viral load monitoring. How are we going to make this happen for the people who need it most? And that includes across the globe and worldwide access of CAB-LA. So I will stop there. These are references for your use. And thank you, and take any questions at this time.
Thanks so much, Colleen. That was an amazing tour de force presentation. We've got lots of questions for you.
Uh-oh.
So let's start out. You know, you were very clear about dorsogluteal and ventrogluteal administration being the only acceptable locations for injection. What are your thoughts on anterior thigh injections? Because there's some people who just can't get it in the gluteal region, period. We have some data in the treatment space about that. What do you do?
Yeah, at this point in time, we're not using it in outside of the ventrogluteal dorsal gluteal space. I'm not sure if you have any different opinions on that, Rafi, but we're not doing it.
Yeah, no, I agree. It seems like the PK is okay, at least in the treatment space, but it was not well tolerated, right? I think 70% of people actually preferred the gluteal space in terms of injection site tolerability. So we're not doing it.
Yeah.
Great. So, Colleen, when you have somebody who's doing well on oral tenofovir-based PrEP in your clinic, and they say, hey, should I try this injectable thing? I'm doing fine, but you know, it might be nice not to have to remember, but I'm doing fine. What do you say to people about cabotegravir in that setting?
Yeah, I think it's almost exactly the same conversation that Adia outlined in the last session. It is a very individual selection for those people that are willing and to come back to the clinic, that, you know, they really would prefer to come see us every 2 months and get that injection versus actually put pill in mouth every day. I think you see very divergent things. Some people are just thrilled to be on injections and not have to remember to take something every single day, and coming to clinic every 2 months is no big deal. Where others are, just think that the clinic visits are such a burden on their schedule that they're just fine with that oral pill. So again, it's an individual discussion. I think where I see use of cabotegravir and even on-demand PrEP is offering people another option when oral PrEP is not working for them. That's where I see it to be really most important. It's like, okay, oral PrEP is not good for you. Taking something every day is not working for you. Let's talk about injections. Let's talk about on-demand PrEP. Give them something else to be able to use to keep them HIV negative.
Love that approach. So we have a question from the audience. How long, if you have a positive result on your HIV screening and somebody on cabotegravir PrEP, what interval do you wait before retesting?
I don't. As soon as they can turn around and come back to the clinic. No interval, which in reality usually ends up being a few days to a week. If because usually it's that viral load that will pop positive first, and then if that takes a day or two to get back, and then you're contacting the patient and it takes them a day or two to get back, so it ends up being a few days. But I don't wait. I test immediately right away, and I order every test I possibly can. That's a little bit of a joke, but I'm mindful of choosing which tests are important. But I order every diagnostic test that is available to me at my institution, and that's what I would recommend, because you need all of the data. You need all of that data in context of a very detailed behavioral history, STI history, other concomitant infections or new medications that people have tested. You need all of that data available and in front of you as you try to sort through this very, very difficult situation.
No, perfect. Thank you. So Colleen, you talked about this issue of resistance during the tail, that we haven't seen it in the clinical trials. So there was this strategy taken in the clinical trials of using a tenofovir-based PrEP regimen to cover the tail. Are you doing that in clinical practice?
Well, and I think even the trials showed us people don't take the oral tenofovir for the tail. If they want to stop PrEP, they want to stop PrEP. They're not necessarily caring about switching to a daily oral regimen. And so I think even if it's recommended, if it's actually happening is the question. And I think it's unusual for that actually to happen, where someone says, okay, I'll take a pill every day for a year just in case. In general, I think it's people that either are disappearing from you because of any number of things that are going on in their lives, or it's people that say, I'm not at risk anymore. I don't want to be on PrEP anymore. So I'm just going to stop. And then they don't take the daily PrEP. I would still offer those people 2-1-1 PrEP though, in the event that there is risk that they're not anticipating for the future. So I would make sure they have something on hand to cover those, or NPEP for that matter.
Great. Great. How do you bridge people who are late for injections? Do you give them a supply of oral PrEP to keep at home, or how are you handling those delayed injection situations?
We're learning. We've been, and I'm in the Southeast, I'm in Atlanta. We've been extremely late adopters of injectable PrEP outside of the clinical trial setting. And so that is something that we're learning. Again, I've been curious and asking my colleagues around about how other people are managing that. Are they having trouble with insurance approving having injectable and oral on hand? Because that would be ideal, right? That they have some oral on hand for a missed injection. But I don't know that everyone's going to have a payer source for two forms of PrEP. So I think that is a really, really difficult question to answer. And I'm not sure what the right answer is. And I would love to hear how others are also managing that.
No, thanks, Colleen. I think it's really, really challenging, right? I think the recommendations in the package insert are very difficult to actually implement, right? I mean, they include, have people have a supply of oral CAB at home, which really is completely impractical. But it's very hard, and I've not been able to successfully bridge anyone. Okay. Unfortunately, Colleen, we're. Oh, sorry, Sue. Go ahead.
You were just going to say what I was going to say, so I'll let you say it.
Oh, okay.
At a time.
Colleen, thank you for a great discussion and for taking so many of our questions. We have to move on, but we'll try and answer people's questions in the Q&A that we weren't able to get to. But Colleen, thank you so much for that really thorough and thoughtful conversation. We so appreciate you joining us.
Thank you. Bye-bye.